This is Focus on Your Health. It's brought to you by Kingman Regional Medical Center in historic Kingman, Arizona. I'm T.G. Lafredo. Dr. Drew Albright is a general surgeon at KRMC. He's trained in surgical treatment of the bowels, breast, thyroid, and foregut, among other parts of the body. He performs advanced laparoscopy and endoscopy, hernia repair, surgical treatment of traumatic injury, and many other conditions. And he's my guest today. Dr. Albright, welcome to the program.
Thank you very much. Good to be here.
It's good to be here. Thank you. We're in your office. We're here at Mojave Surgical Specialists. And I just listed a bunch of procedures that you handle. We'll maybe talk about some of those in a bit. But I am curious, what is a day in the life of a general surgeon?
So a day in the life of a general surgeon, there's a lot of variety, which is what drew me to the field initially. We work with many different problems, including anything in the abdomen. We do endoscopy for colon cancer screening. We also deal with traumatic injuries at the hospital. So we get a good variety of things. We can see anything from gallbladders to hernias to hemorrhoids to any kind of bad trauma injury that you may have.
Yeah, no 2 days are the same?
That's right, yes.
I was checking out the trajectory of your career, and I see that before you went to medical school, you worked as a certified nursing assistant. Can we talk a little bit about that chapter?
Yeah, so I was a certified nursing assistant, or CNA, in the years while I was in college, pre-med. I worked as a CNA on the weekends. That was a job that allowed me to sort of see if I wanted to pursue medicine. My dad was an ER doctor and said, hey, if you are interested in medicine, you should work as a CNA and see if working with patients is something you want to do, because as a CNA, you're helping patients with those really sort of personal care, intimate sort of things that they require while they're in the hospital. So that's kind of what allowed me to talk to patients and be able to relate to the nursing team, which is very important to relate well and treat your nursing team with respect as a physician. And so I was part of that team for a number of years. I think I worked a total of like 6 years as a nursing assistant before I went to med school. So I got to be right there with the patients, helping them with bed baths and brushing their teeth and helping them walk. And so that allowed me to kind of see that side of patient care.
This would have been probably when you were in your early 20s, something like that?
Correct. Yes.
That's quite an experience. Pre-med is plenty of work as it is, right?
Yeah.
How did you fit that all in, working weekends and still doing your studies?
It was long days because they were 12-hour shifts, but you just try to find time to study and just get it in when you can. So it worked out in the end.
You said your dad was an ER doc. Does he still practice?
He has since passed away, but
sorry.
Yeah, it's okay.
Yeah. Did you get when you were a kid, did you get the opportunity to go to work or shadow him at all?
Many times, yeah. So I'd go into the hospital with him a lot and see him in the ER. Also, I would go and round on patients with him on the weekends. That was good for me to see. I never really wanted to pursue medicine with seeing that growing up until I saw surgery. That's when I decided, that's what I want to do, is actual surgery. I never wanted to go into ER medicine or really anything else until I actually was in the operating room seeing it for myself.
What was it about surgery? What was it that in that experience for you?
I just have always thought anatomy and physiology was really fascinating, how our bodies work and can heal disease on their own. And so when I saw a real surgery in person and saw the real anatomy with a real beating heart and real lungs that were going up and down, I was like, that is incredible, and that's what I want to do.
In your life away from medicine, are you kind of wired the same way where you love to know how things work? Do you geek out on schematics of electronics? Do you like to take things apart?
Not particularly. Okay. I get frustrated with that stuff pretty easily, though. But in general, like if it's something that I'm interested in or that I feel like I can achieve, I will go for it, pedal to the metal, full throttle. That's kind of my personality, and that's worked out with surgery. So
I was just thinking about a friend of mine who does a bunch of mechanical drawing and detailed stuff. And when I see a schematic, I'll say, hey, I think you want to see this. And he's like, oh, I love this stuff. I love to see how things work. Yeah. And as a surgeon, that's kind of the way you view the human body, right?
Yes. Yeah. I think with me being a DO, if you're a physician, you either have an MD degree or a DO degree.
Yeah. What's the distinction there?
So I'm a DO, and we do much of the same training an MD does. It's just our medical school curriculum is a little bit different, to where the osteopathic philosophy is if we can provide the right environment for the body to heal itself, that's better for the patient. So that's one of the principles of osteopathic medicine, is we say if we can help a patient's body do most of the work, which is what it's built to do, then we try to let your body heal, do most of the healing if we can. Obviously, there are surgical problems that require a scalpel to fix. And so I like having both of that ability, the ability to kind of approach patient care with those tools.
I can't help but I want to return for a moment to, you're saying about your father as an ER doc. And of course, as you mentioned, he's no longer with us. Do you ever find yourself in your practice kind of thinking of him or channeling maybe the way he would work with patients, lessons that he might have shared with you?
Yeah, all the time, almost every day. In medical school, when he was still alive when I was in medical school. And so we had a lot of fun talking about like, oh, one day when I'm a surgeon, we can be in the operating room, you can assist me. Yeah. And so we had enjoyed talking about that, and we're looking forward to that. And he actually was interested in surgery when he was in medical school. Mm-hmm. But back in those days, surgery training was really brutal. I mean, you were working over 120 hours a week. You were it was a rough life. And when you had a family and young kids, it was not really conducive to having a good home life. So that's not something he was wanting to pursue, but he was always interested in surgery. So he kind of was liking seeing me pursue surgery in a different era, because he said, yeah, that's a great field and you get to directly help patients with your hands. And so we had a lot of fun talking about that.
Surgery training was brutal. And also a lot of the old docs who were teaching, I think they saw it as their job was to haze the next generation.
Yeah.
Right? They were the gatekeepers.
Yes.
Was that still going on when you were training?
It was definitely phasing out, but some of it was still there.
Yeah.
Rightly so. I mean, back in the old days, it was almost militant. The training was militant with, how we have this term in surgery called malignant. If someone is malignant, which in medical terms means cancerous, but we use the term malignant to describe how mean someone would be. So if a particular program, surgery training program, was notoriously malignant, meaning their surgeons who trained their residents were really mean and just very hard on them, we would consider that a malignant program. The program that I went to was definitely not like that. I feel like it was all the good parts of a training program without the malignancy of mm-hmm. the rough personalities and getting yelled at and, mm-hmm. Kind of that shaming that was happening a lot 30, 40 years ago.
Is there still a prevalent belief that the malignant programs turned out better quality surgeons?
No, I don't think so. The malignant part of programs where they were so hard on you, I think was for a good reason, because it was teaching you the responsibility of a surgeon. It was saying, these are people's lives in your hands. So this is not a time to mess around. You need to be on top of your stuff. You need to know what you're doing. And so we're going to drill it into your head, beat it into your head day in and day out, night and day, And so that's what I think the older generations were trying to convey was, this is serious business and you need to be on your A game in order to treat these patients correctly. And so I still agree with that. But I feel like there are better ways of training nowadays. We still want to get the experience, but, to demean someone, to yell at someone, these are obviously not dumb people that have gone through medical school and college and done very well. These are not dumb people, but you get treated like you're a 3-year-old. Yeah. And so that's just part of the whole training and kind of the hazing process that you described.
Right. You wouldn't treat your 3-year-old like that, really.
Right. Yeah.
Do you have residents rotate with you?
I do.
Yeah. You want to convey that it's serious business. They're not stupid, but some of them may need that wake up call.
Yeah.
You try to find that balance.
Yeah. Yeah. The residents I work with are really good. They come over and rotate with us for a month at a time from a Las Vegas program. I think one of the things that I try to focus on as a attending surgeon training a resident is getting them to think about the aspects of a surgery, meaning what options do you as a surgeon have available to treat this patient? Because there's more than one way. There's more than one way to do a lot of these procedures. And I try to teach them a way that makes sense. And so they can, in their training, they will take a little bit of each surgeon they work with and probably integrate it into something that makes sense for them.
If you're just joining us, this is Focus on Your Health. I'm T.G. Lafredo, and this week I'm coming to you from Mojave Surgical Specialists. My guest is Dr. Drew Albright. He is a general surgeon here. Dr. Albright, we dove into your background, and I just wanted to finish up that conversation about practicing as a CNA when you were a young guy. And you're describing, that up close and personal work, that bedside work with patients. Does that in any way inform the work you do now, all these years later?
Yeah, I think that experience as a CNA has allowed me to work well with the nursing staff, which is huge in the operating room and post-operatively. The nurses that take care of our patients on the floor, and even the nurses in the emergency department. Learning how to appreciate the nursing staff. If you're a surgeon, and you don't know how to relate to the nurses or get them to trust you or want to work with you, nurses can make your life a lot harder. And so I like to try to get the nurses on my side. And I feel like as a CNA, having that experience, I can kind of relate to the work that they do for our patients. It's allowed me to talk to patients on a more human level rather than like I'm the surgeon, you're the patient. Because I kind of have seen and helped patients get out of bed and do their activities of daily living, brushing their teeth, getting dressed, all that kind of stuff I've been a part of. And so I think it allows me to relate to patients on a more human level.
Your response foreshadows my next thought, which was I was wondering if you'd talk a little bit about the surgical team, your teammates here.
Mm-hmm. My colleagues.
Your colleagues.
In my practice, yeah. So we work as a team. Dr. Nielsen, who's the newest partner in our group, is a general surgeon who's done specialized endocrine surgery, where he focuses on adrenal glands and thyroid, parathyroid disease. And so that's something that we've been able to offer the community with him starting. But we all are able to practice general surgery, so gallbladders, hernias, trauma, appendix, anything like that falls within the realm of general surgery, including cancer, breast cancer, colon cancer, all that stuff we are able to effectively treat as general surgeons. But we do work as a team. We help each other. If someone needs help in the operating room, we're all very close and we can jump in and help each other, no problem.
Is it common, say, leading up to a procedure where you'll say, I need someone else on this, or perhaps I'm looking at this image, can I get your opinion on that?
I wouldn't say it's common, but I think we understand that the option is there if any of us need help. We're all always available for each other. Mm-hmm. So, but I think as you get further and further into your career and you gain this experience through doing, you probably require less and less help in the operating room and decision making, just because you've seen so many of them. You kind of know what to do at that point.
Yeah, so the guys over at the cancer center kind of impressed upon me that when you talk to your colleagues about these things, that's not a sign of weakness, that's a sign of strength.
Yeah, I think one of the strengths in medicine and a community like Kingman and KRMC is the collaborative effort amongst surgeons and medicine doctors and oncologists. Collaboration is great for the patient. You want these smart minds looking at your case from all different angles, and we all come up with the best treatment for you. Mm-hmm. And you're right, there is no weakness in having multiple people review your case and looking at it. So I think that that's a real strength.
Well, it's not a secret that Mojave County is a medically underserved area. For example, there are fewer opportunities to refer. As you said, sometimes patients get shipped out for certain conditions. Do you feel additional pressure to be an expert in more things, to study more, to stay up on it more?
Mm-hmm. Yeah. And that is one of the draws of coming and being a general surgeon in a rural community like Kingman and Mojave County is your scope of practice is actually bigger here. If you are a general surgeon in a big city like Las Vegas or San Diego, you're going to be confined to a very small scope of practice, handling only a handful of different problems. If you're a general surgeon working in an area like Mojave County, you are able to handle a lot of things that you wouldn't otherwise be able to do, because in a big city, everything gets sent to a specialist. So here, you're it. Especially as a general surgeon, you get to do, endoscopy, you get to do trauma, you get to do cancer surgery, where in a big city, that would all be sent out to a specialist.
Yeah. So you better be good.
So it's, it's good. It was a good place for me to come right out of training, because I gained a lot of experience in a short amount of time. And that I feel like has allowed me to be a more comprehensive physician.
Tell me a little bit about the role technology plays in the work that you do in the operating rooms.
Yeah, so technology, we see increases in technology often. And, other than our medical records going to a completely electronic system where all of the records are in a computer, that's allowed us some good and some bad. with medical documentation. I think for surgery specifically, we're getting better with minimally invasive technology in the operating room. Probably the most recent tool that we have showing an increase in this technology is the Da Vinci robot. We do robotic surgery, which has allowed us to have better visualization of the tissue, finer dexterity, quicker return to normal activities for patients, less post-operative pain, less narcotic use, and obviously less scarring and risk of wound infection.
This is a change even from when you began your training. You were doing all that work by hand, generally?
The technology was there, but it was not being used as much where I trained, at least. But now over the last 5 to 10 years, we're seeing an explosion of what is really capable with the surgical robot, and it's really benefiting patients from what we're studying.
You alluded to how that often means better outcomes for patients and shorter recovery time. Can you share a little bit about that?
Yeah, so if you think of back in the old days where anything in your abdomen that needed to be removed, you got a big cut on your abdomen and the surgeon had to do it by hand, and which created a lot of pain. You have a big cut on your belly, so there's higher risk of wound infection. There's a higher risk of hernia formation, making a big cut like that. And then things progressed into laparoscopy. So we go in with a camera and small instruments through the abdomen, and that's been good too. And then the robot's even been better than that because the way the robot is docked to the instruments on the patient has allowed for less manipulation of the patient's abdominal wall, which overall reduces the trauma to their tissue, which equals less pain postoperatively. And the robot has allowed us to see the tissue a lot better because it's 10x magnified with 3D vision. So it's allowing us to see magnified view of the anatomy and finer dexterity with the robotic instruments. So that's all translated into better patient outcomes.
I want to ask you a little bit about the importance of patient education. We just talked about how technology has made surgery less invasive and often has improved outcomes and recovery times. But just the same, patients have a lot on their minds before undergoing surgery, and you have to help them through the process. What is that like? How do you approach that?
Yeah, I think that's one of the most important aspects of seeing patients in the clinic and talking about doing surgery on them is one of my primary objectives when I see patients in clinic and we're discussing a surgery that they need, I want the patient and their families to understand what we're doing. So I take a lot of time to explain their disease process and explain the actual surgery that we're doing and the reasons why we're doing it that way so that the patient has a pretty good grasp on, oh, here's my problem, here's what we're going to do to fix it. And I want people to walk out of my office knowing what we're doing and then feeling confident in what we're doing.
As a surgeon, you have a lot of insight on disease states in the human body, and I'm sure there are genetic factors, sort of that nature versus nurture conversation. But regarding health maintenance and preventive care, what would you like patients to know? And I mention this because just as I was setting up the mics, you came in and you were kind of muttering, saying, sometimes I get patients and they're not ready for surgery. There's a lot more to do before that, right?
Mm-hmm. Yes. When we as physicians talk to patients about their health, primary care doctors see more of this than we do, but it's something that we deal with. We want patients to understand that, obesity is a problem, their smoking is a problem, their diabetes and control of their blood sugar is a problem, all when considering surgery. So that's been the swan song of every physician ever, is to eat healthier, exercise regularly, drink more water. All those things are really important. And, a lot of it comes down to education. A lot of patients might not understand, oh, I can't eat Lucky Charms for every meal. There's actually consequences to that. And so those are things that sometimes need to be explained. It's simple, but it's also very difficult for patients to do, to maintain a healthy lifestyle, because it might mean you can't buy the really cheap stuff at the store. You have to try to exercise regularly, and it's a real lifestyle shift for people. So a lot of people aren't ready to make that kind of commitment to their own health. When we see surgical patients with chronic health problems, then this kind of puts them behind the 8 ball when going in for a surgery, because when we do surgery, we're creating trauma to the body to some extent. Your body needs good nutrition and a somewhat regular state of health in order to heal surgical wounds. So this is why we talk to patients about the importance of significantly reducing or ideally quitting smoking before a surgery or getting their diabetes under better control, because these can all be detrimental to their surgical recovery too.
Not long ago, I read an article by a physician, and she was saying so many of her patients are obese that she stopped addressing it because there's this feeling in the room that she's beating up on the patients. And her argument in the article was, look, they know that they're dealing with this. They don't need me to beat up on them. And we need to have an open relationship and an easy conversation. I thought it was really interesting to read that. I was concerned about it. Mm-hmm. Can I get you to opine?
Well, and obesity, smoking, diabetes control are something that we always bring up to patients. And it's one of those things that the patient kind of has to take that next step too and take some accountability for their health. And so I can see where a physician would kind of shift their practice to be like, well, I don't really discuss it in detail anymore because I've talked about it several times and provided resources in order to help the patient, and they, maybe for whatever reason can't or won't take those next steps for their own health. It's frustrating as a physician because they have the ability. Your body does not want to be unhealthy. Your body wants to be healthy, and it doesn't want to be obese. It doesn't want to have diabetes. It wants to get healthy, but it takes the patient to kind of have a little bit of their own accountability to make a lifestyle change, and it's hard. It is hard when, say, you grew up in a household that smokes and you yourself smoke. I mean, that is not an easy thing to quit. So I understand that mentality from a physician. I think, me personally, I think it's always worth bringing up and just asking the patient, hey, what are you doing? Or what are you doing to lose weight? Have you changed your diet? Or tell me something that you've done. Yeah. So I think that's still important to sort of hold them accountable to.
I think so. I mean, I could gather that she was coming at it from an angle of empathy, but another way to look at it is she's kind of surrendered. And part of your job, I think, as a doc is that sometimes you have to fight the good fight even when it's not that popular.
Yeah. That's true. Yeah. And we never want to belittle patients and make them feel lesser, but also sometimes getting a little bit of, hey, part of this is on you, does jumpstart something in them to say, you know what, they're right. Let me put some effort into this and work on it. So,
well, Dr. Albright, in the moment we have left, I would like you to look to the future a little bit. When you think ahead in your career and your work here at KRMC, what might be on the horizon?
So I think from a general surgery standpoint, if we can continue getting education out into the community about what we as general surgeons do and saying, hey, these are the types of problems that we deal with regularly. The two plugs that I'll put in for just anyone listening: get your colonoscopy, get your mammogram. Those are life-saving screening tools that we have that can prevent cancers. And so I always tell people, when you can, make sure you're up to date with your colonoscopy and your mammogram, because those are life-saving screening tools that we as general surgeons can treat if we find something early, and that overall saves lives. Looking to the future, I think what I would like to see for our practice in the hospital is to be able to offer more specialized surgical care, where maybe we offer more procedures, maybe dealing with the vascular system, or maybe the colorectal system that we don't have here yet. I would like us to also see integrated technology into our clinic, like maybe some AI platforms with patient care, like office notes and consultations, as well as integrating AI into the operating room and surgeries, when it's coming out. And it's something that I would like us to sort of just be current on and be on the forefront of these. I think Kingman Hospital is, we're small, but I think we pack a punch. With the acuity of the patients that we see, I think we definitely have reason to pursue these kind of up and coming, cutting edge type procedures and technology. And I would love to see us use that to really improve the outcomes of our patients.
That is Dr. Drew Albright. He is a general surgeon at Mojave Surgical Specialists. You can reach his office at 928-681-8720. That's 681-8720. Dr. Albright, such a pleasure to speak with you today. Thank you so much for your time.
Thank you for having me. My pleasure.
And that is the program. That's Focus on Your Health. I'm T.G. Lafredo. Thank you for listening. Stay healthy, and we'll catch you next time.